Good afternoon, everybody. This is one of the abstracts from SABC, and it is related to contrast-enhanced mammography. Now, we know this is the upcoming modality which has shown promising results. So the same has been kept as a background for breast cancer surveillance by authors from Royal Melbourne Hospital in Australia. What they have focused is what they have, how they planned was that it was a retrospective analysis, and they included patient who had a personal history of breast cancer, saying that these are the group of the patients who are at increased risk for local recurrence or developing a new primary breast cancer. So actually they are also advised for regular surveillance imaging, and that is why they included all these patients. According to NCCN guidelines, annual mammography is what is advised for them, but not the other modalities in their setup. So whenever there is dense breast, or whenever the patient has a personal history or is a high-risk patient, would warrant a supplement screening with either ultrasound or MRI. So this scenario is kind of slightly different from our scenario, because they have studied that supplement ultrasound, though it increases cancer detection rate, but since it is associated with low specificity and it would warrant large volumes of surveillance, they would want they have tried to compare if the recall rate or the ultrasound rate can be reduced while using contrast-enhanced mammography for such patients. So contrast-enhanced mammography, we know that has high sensitivity and good specificity for picking up cancers, which are seen as enhancing lesions in their institute. And by practice, they had started doing and offering contrast-enhanced mammography as the imaging modality starting from 2018. So that is how they have included the patients, and that was the data set for them. In one setting only, they have obtained two-dimensional full-fledged digital mammography, three-dimensional, that means tomosynthesis and contrast-enhanced, with the aim to review the outcomes of all those who are undergoing first surveillance contrast-enhanced mammography. The data has been recruited from the departmental database starting from October 2018 to June 2020, and all the radiological and pathological details were extracted from their databases only. So what they say is that they have included first surveillance contrast-enhanced mammogram with two-dimensional, of course, and all the mammograms were read, and the data which was collected was BI-RADS, mammographic density, background enhancement, and they correlated it with the gold standard of histopathology. And they tried to estimate if contrast-enhanced mammography could detect additional lesions and what were those lesions, plus if introduction of CEM could reduce their ultrasound rates. So they could include 1,195 patients, out of which 961 had bilateral CEM, 234 had unilateral, that means the patient had already undergone mastectomy for index surgery of the other side. What they realized was that whenever they have used CEM, they had markedly reduced ultrasound screening. Out of these 1,195 patients, 1,000 patients had prior invasive cancer and 193 has only DCIS. So the results which they have postulated and they have presented had kind of mixed findings. What they say that out of all these patients, 33 were the ones who were only reported on CEM, and they had done 70 biopsies. Out of this, 37 were true positive and 42 were false positive. And out of those 33 patients which were detected only on CEM, 22 could have a correlate on 2D or 3D, that is tomosynthesis mammogram, and 15 were only seen on CEM. Out of those 15, few were DCIS, few were invasive, and predominantly the ladies have denser breasts, that is BI-RADS C category. Of all these findings, 15 had true positive and 18 had false positives. The elaborated details about these have not been included in the abstract per se, but since their aim was to evaluate how much ultrasound detection or ultrasound utility had reduced, so they compared the same data set with the 1 year back data, the ladies who had undergone same mammogram surveillance a year back before they introduced CEM. So what they found was that out of 2,781 mammograms, only 891 required ultrasound 1 year prior. And after the introduction Out of almost 3,000, only 400 ladies they subjected to ultrasound. So they found that they had 55% reduction in bilateral ultrasound. So it is just to summarize that 1195 patients underwent either bilateral or unilateral CEM, had both IDC and DCIS, so not the other variants were included. 33 lesions were detected on CEM, and true positive were 15 and false positive were 18 on biopsy, when biopsy was kept as gold standard. So they concluded that routine CEM should be the main imaging strategy for surveillance of the patients who have high risk of recurrence and have previous history of breast cancer, because it was able to highlight additional findings which could change the management outcome. And this was associated with major reduction in bilateral ultrasound use. Further assessment obviously is warranted because it was predominantly the kind of study which could evaluate only the ultrasound, and there was no two arms to say whether it is actually there or not, and long-term impact was not studied. Although these results and the study is quite promising, while going through this, there were some concerns which came into my mind. Considering our scenarios, which was that they have not elaborated on what false positive biopsies were done. And also, if we go back to the results, it was not clear what 70 biopsies are we discussing about and what are these 33 biopsies. And maybe we would be more keen for the full text to understand what were the false positive rates. That was one thing. Similarly, for false negative, and if we could get a positive predictive or negative predictive value, which I'm sure we'll get soon, and whether we'll be able to replicate the same study in our scenario, because at this point of time, we are struggling for digital mammography per se. And if we are trying to compare whether the ultrasound should be reduced if we introduce contrast enhanced mammography, though it is an ideal situation, but it is still a far-fetched goal for our scenario. Thank you.